I eliminated my hypertension medications completely in 14 months. My blood pressure dropped from 148/92 on 3 medications to 118/74 with 0 medications. I'm Dr. Walter Miles, professor of genetics and metabolic biology at a research university where I've spent 15 years studying vascular remodeling and cellular aging. Today, I'm sharing the exact 4-mechanism protocol that reversed my hypertension at the cellular level. Not managed it, reversed it. Before I explain what worked, you need to understand what hypertension actually is, because everything you've been told is incomplete. Your doctor says hypertension is elevated pressure in your blood vessels, too much force against arterial walls. The solution? Medication to lower that pressure. Take a diuretic to reduce fluid volume. Take a calcium channel blocker to relax smooth muscle. Take an ACE inhibitor to block vasoconstriction. Your pressure numbers drop. Problem solved. Except the problem isn't solved. The medication manages the symptom while ignoring the disease. Hypertension isn't a pressure problem, it's a structural problem. Your arteries have undergone pathological changes at the microscopic level. The endothelial lining is damaged. The vessel walls are calcified. Nitric oxide production is impaired. Insulin has locked your kidneys in sodium retention mode. These are the actual mechanisms driving elevated pressure. And here's what your doctor doesn't tell you. Medication doesn't fix any of these mechanisms. Pills manipulate pressure readings without repairing vascular damage. This is why people on blood pressure medication for decades still have strokes and heart attacks. The numbers look controlled, but the vessels remain diseased, inflamed, and vulnerable. I discovered this personally when my blood pressure reached 148/92 at age 51. My physician prescribed lisinopril 10 mg. My pressure dropped to 132/84. Success by conventional standards, but I requested additional testing, endothelial function assessment, arterial stiffness measurement, advanced metabolic panel. The results shocked me. Despite controlled pressure numbers, my endothelial function was severely impaired. My pulse wave velocity indicated significant arterial stiffness. My fasting insulin was 16 μU/mL, 60% above optimal range. The medication was masking symptoms while underlying vascular pathology progressed. I decided to address the mechanisms rather than just the numbers. What I discovered through research implementation changed everything. Mechanism number 1, endothelial glycocalyx restoration. Your arterial endothelium, the single-cell layer lining every blood vessel, has a protective coating called the glycocalyx. This microscopic layer is only 2 to 3 micrometers thick, composed of glycosaminoglycans and proteoglycans. You cannot see it with the naked eye, but it's one of your cardiovascular system's most critical structures. The glycocalyx serves 3 essential functions. First, it creates a frictionless surface, allowing blood to flow smoothly without turbulence. Second, it prevents inflammatory molecules and immune cells from adhering to the vessel wall. Third, it mechanotransduces shear stress from blood flow into biochemical signals that trigger nitric oxide release. When your glycocalyx is intact, your vessels remain healthy and responsive. Nitric oxide production is normal. Blood pressure stays regulated. But chronic hyperglycemia, oxidative stress, inflammatory cytokines, and dyslipidemia progressively degrade this protective layer. The glycocalyx fragments and sheds into circulation. Once degraded, your endothelium becomes exposed. Inflammatory molecules like TNF-alpha and IL-6 bind directly to endothelial cells, activating NF-kappa-B inflammatory pathways. Leukocytes adhere to the vessel wall. Oxidized LDL particles penetrate the subendothelial space. Atherosclerotic plaque formation begins. Simultaneously, loss of mechanotransduction impairs nitric oxide synthesis. Your vessels lose their ability to dilate appropriately. Vascular resistance increases. Blood pressure rises. This glycocalyx degradation is measurable. Circulating syndekin-1, a glycocalyx component, correlates with cardiovascular disease severity. Research published in Circulation demonstrated that elevated syndekin-1 predicts major adverse cardiovascular events independent of traditional risk factors. The critical question, can you regenerate the glycocalyx? Research says yes, but not with medication. Statins don't restore glycocalyx. ACE inhibitors don't rebuild it. Beta blockers certainly don't. Regeneration requires specific substrates and protection from ongoing damage. First, you must eliminate glycocalyx destroyers. Hyperglycemia is primary. Every postprandial glucose spike above 140 mg DL glycates glycocalyx proteins through non-enzymatic reactions, creating advanced glycation end products that stiffen and fragment the structure. I implemented strict postprandial glucose control. No meal was allowed to spike my glucose above 130 mg DL. This required eliminating refined carbohydrates completely. No bread, pasta, rice, potatoes, or sugar. I consume primarily non-starchy vegetables, moderate protein, and healthy fats. Second, I supplemented with glycocalyx building blocks. The glycocalyx requires sulfated polysaccharides for synthesis. Fucoidan extracted from brown seaweed species like Undaria pinnatifida provides these substrates. Research in Atherosclerosis Journal showed that 1,000 mg daily fucoidan supplementation for 12 weeks increased glycocalyx thickness measured by side-stream dark field imaging and improved flow-mediated dilation by 18%. I took 1,000 mmol fucoidan daily from a pharmaceutical-grade source verified for heavy metal testing. I also consumed wild-caught fish 3 times weekly for sulfur-containing amino acids, cysteine and methionine, which provide additional sulfate groups for glycosaminoglycan synthesis. Third, I eliminated oxidative stress through polyphenol intake. Reactive oxygen species directly damage glycocalyx structures by oxidizing the protein and carbohydrate components. Polyphenols neutralize these free radicals while simultaneously upregulating endogenous antioxidant systems like superoxide dismutase and catalase. I consumed high polyphenol foods daily: 2 cups of mixed berries, anthocyanins, 2 cups of leafy greens, quercetin, green tea with each meal, catechins, and 85% dark chocolate, providing 20 gram cocoa solids daily. These provided approximately 2,500 mg total polyphenols. The intake associated with significant cardiovascular protection in the Pyridymed trial. After 3 months of this protocol, I had my endothelial function retested using flow-mediated dilation, the gold standard measurement. At baseline, my brachial artery dilation was 4.2%, indicating severe endothelial dysfunction. Normal is 7%. After 3 months, it increased to 9.8%. My glycocalyx had regenerated. My endothelium was producing nitric oxide normally. My blood pressure on medication dropped from 132/84 to 124/78. Mechanism, NRGR2, arterial decalcification through vitamin K2. Arterial stiffness drives systolic hypertension in aging populations. This stiffness results from vascular calcification, the pathological deposition of calcium phosphate crystals in arterial media and intima. This isn't passive precipitation. It's an active process mediated by vascular smooth muscle cells that undergo osteochondrogenic transformation. When I measured my arterial stiffness using pulse wave velocity, the result was alarming: 11.2 ms. Normal for my age should be below 9 ms. This indicated significant calcification and explained why my systolic pressure was disproportionately elevated compared to diastolic pulse pressure of 56 meters. Vascular calcification occurs when matrix Gley protein, MGP, the primary endogenous calcification inhibitor, remains undercarboxylated and inactive. MGP requires vitamin K2 for gamma carboxylation of its glutamic acid residues. Without adequate K2, MGP cannot bind calcium phosphate crystals or inhibit bone morphogenetic protein 2, BMP2, which triggers osteogenic differentiation of smooth muscle cells. The Rotterdam study, following 4,807 subjects for 7 years, demonstrated that participants with highest dietary vitamin K2 intake had 52% lower cardiovascular mortality and 57% reduced severe aortic calcification compared to lowest intake. Critically, vitamin K1 showed no protective effect. Only menaquinones, K2 forms, activated MGP. Intervention trials confirmed K2's calcification reversal capacity. A 3-year study published in Thrombosis and Hemostasis gave postmenopausal women 180 mg menaquinone 7 MK7 daily. Compared to placebo, the K2 group showed significant reduction in arterial stiffness measured by carotid femoral pulse wave velocity and decreased progression of coronary artery calcification. Most Western diets provide less than 50 milligram K2 daily, grossly inadequate for MGP carboxylation. Dietary sources are limited. Natto, fermented soybeans, provides approximately 1,000 milliliters per 100 gram, but most people find it unpalatable. Aged cheeses contain 10 to 30 milliliters per ounce. Supplementation becomes necessary. My protocol included 360 milliliter MK7 daily from Life Extension Super K with advanced K2 complex. I took it with my evening meal containing fats to maximize absorption as K2 is fat soluble. I also ate 50 jurei natto 3 times weekly, mixing it with soy sauce, mustard, and kimchi to make it tolerable. Calcium requires proper trafficking out of arteries into bone. This requires the synergistic action of vitamin D3 with K2. Vitamin D increases intestinal calcium absorption and stimulates osteoblast activity, but without K2 to activate MGP and osteocalcin, calcium can deposit ectopically in soft tissues rather than bone. I supplemented 5,000 IU vitamin D3 daily. My baseline 25 hydroxyvitamin D level was 32 ng/ml, insufficient for optimal calcium metabolism. After 3 months, it increased to 56 ng/ml, the range associated with lowest all-cause mortality. The third critical nutrient is magnesium. Magnesium serves as nature's calcium channel blocker. It competitively inhibits calcium entry into vascular smooth muscle cells, promoting vasodilation. More importantly, magnesium prevents hydroxyapatite crystal formation in arterial walls by inhibiting calcium phosphate precipitation. Most people are magnesium deficient. Modern diets provide approximately 250 milliliters daily when 420 milliliters is required for men. Chronic stress, alcohol, diuretics, and proton pump inhibitors further deplete magnesium stores. This creates a perfect environment for vascular calcification. I supplemented 600 millimolar elemental magnesium daily using magnesium glycinate, the most bioavailable form with 80% plus absorption versus 4% for magnesium oxide. I split the dose 300 milliliters morning, 300 milliliters evening with meals. After 12 months on this decalcification protocol, I had my pulse wave velocity remeasured. It decreased from 11.2 metrius to 8.9 metrius, a 21% reduction indicating significant reversal of arterial stiffness. My pulse pressure narrowed from 56 to 44 millimeters arc. My systolic pressure dropped disproportionately more than diastolic, exactly what you'd expect when arterial compliance improves. Mechanism number 3, nitric oxide restoration via endothelial training. Nitric oxide is the master regulator of vascular tone. Synthesized by endothelial nitric oxide synthase, enos from L-arginine, NO diffuses into vascular smooth muscle where it activates soluble guanylate cyclase, increasing cyclic GMP levels. This triggers smooth muscle relaxation, vasodilation, and blood pressure reduction. In hypertension, ENOS becomes dysfunctional through a process called uncoupling. When the critical cofactor tetrahydrobiopterin, BH4, becomes oxidized, ENOS produces superoxide radicals instead of nitric oxide. This creates a vicious cycle. Oxidative stress depletes BH4, causing ENOS to generate more oxidative stress, further depleting BH4. Your enzyme for vasodilation becomes an enzyme for vasoconstriction. I couldn't measure ENOS coupling directly, but flow-mediated dilation serves as a functional assessment of endothelial NO production. My 4.2% baseline FMD indicated severe NO deficiency. Restoring NO production requires 3 approaches: protecting BH4 from oxidation, providing ENOS cofactors, and training the endothelium through mechanical stimulation. For BH4 protection, I relied on the polyphenol protocol described earlier. Specific compounds are particularly effective. Vitamin C regenerates oxidized BH4, folate prevents BH4 degradation, and vitamin E protects ENOS from oxidative inactivation. I ensured adequate intake through food. 200 milligrams vitamin C from bell peppers and citrus, 400 milligrams folate from leafy greens and legumes, 15 milligrams vitamin E from almonds and sunflower seeds. I did not supplement L-arginine despite its theoretical appeal. Research shows that in patients with endothelial dysfunction, Arginine supplementation often fails because the problem isn't substrate availability, it's ENOS coupling. Furthermore, excess arginine can be metabolized by arginase to ornithine, reducing arginine availability for no synthesis. Addressing BH4 depletion is more effective. The second approach involves dietary nitrate supplementation. Vegetables high in nitrate, arugula, spinach, beets, provide an alternative no-generation pathway independent of eNOS. Dietary nitrate is concentrated in salivary glands, secreted into saliva, converted to nitrite by oral bacteria with nitrate reductase activity, swallowed and reduced to no in acidic stomach environment and hypoxic tissues. Research in Hypertension journal demonstrated that 400-500 milliliters dietary nitrate daily reduces blood pressure by 8-10 mmHg systolic in hypertensive patients. The effect persists with chronic supplementation. I consumed 200 green raw arugula daily, approximately 500 meter nitrate, in a lunch salad. I also drank 70 milliliter concentrated beetroot juice each morning, 250 milliliter nitrate. Critical, I eliminated all mouthwash. Antiseptic mouthwash kills oral bacteria required for nitrate to nitrite conversion. Studies show chlorhexidine mouthwash for 7 days completely abolishes the blood pressure reduction from dietary nitrate. The third and most powerful approach is endothelial training through isometric resistance. When you perform sustained isometric muscle contractions, you compress blood vessels supplying that muscle. Upon release, reactive hyperemia occurs, a surge of blood flow creating intense shear stress on the endothelium. This mechanical stimulus activates ENOS and upregulates its expression. Research published in the American Journal of Hypertension demonstrated that isometric hand grip training, squeezing a hand grip device at 30% maximal voluntary contraction for 2 minutes, repeated 4 times with 1-minute rest intervals performed 3 days per week, reduces blood pressure by 10.9 mmHg systolic and 6.2 mmHg diastolic after 8 weeks. The effect rivals first-line antihypertensive medications. I implemented this protocol precisely. I purchased a calibrated hand grip dynamometer, measured my maximal voluntary contraction, 48 kDARs, and performed training sessions at 14.4 key or 30% MVC 3 times weekly. The contractions were uncomfortable but tolerable. After each session, my hands were noticeably warmer, evidence of enhanced blood flow and no production. I also practiced nasal breathing exclusively, including during exercise. Nasal passages produce NO through nitric oxide synthase expressed in paranasal sinus epithelium. This NO is inhaled with each breath, reaching 200-300 ppb concentration compared to 5 ppb in mouth breathing. Studies show nasal breathing increases circulating NO metabolites by 600%. After 4 months combining these NO restoration strategies, my flow-mediated dilation increased to 9.8%, as mentioned earlier. My blood pressure on medication dropped to 118/74. I began working with my physician to reduce medication dosage. Mechanism? Number 4, insulin normalization for renal sodium handling. This mechanism explains why sodium restriction fails for most hypertensive patients. Your kidneys regulate blood pressure by modulating sodium excretion. When sodium intake is high, kidneys should excrete the excess. When intake is low, kidneys should conserve. This feedback maintains stable blood volume and pressure, but hyperinsulinemia disrupts this system. Insulin directly stimulates sodium reabsorption in the proximal tubule via enhanced Na plus H plus exchanger activity and Na plus C K plus ATPase expression. Insulin also activates the sympathetic nervous system, triggering renin release, which initiates the renin-angiotensin-aldosterone cascade, all promoting sodium retention. Research in Hypertension journal showed that in hyperinsulinemic patients, sodium restriction fails to reduce blood pressure because kidneys remain locked in retention mode regardless of dietary intake. The limiting factor isn't sodium consumption, it's insulin-mediated renal dysfunction. When I tested my fasting insulin, the result was 16 mean μmol. Optimal range is 2 to 6 μmol. My insulin was elevated despite normal fasting glucose, 94 mean DL, and normal HbA1c, 5.4%. This is classic hyperinsulinemia preceding dysglycemia. Insulin rises years before glucose becomes abnormal. Normalizing insulin requires addressing insulin resistance at the cellular level. Skeletal muscle is the primary site of glucose disposal, accounting for 80% of insulin-mediated glucose uptake. When muscle becomes insulin resistant, usually due to intramyocellular lipid accumulation and mitochondrial dysfunction, the pancreas compensates by secreting more insulin. The most effective intervention for improving insulin sensitivity is resistance training. Muscle contraction acutely increases glucose uptake via insulin-independent GLUT4 translocation. Chronically, resistance training increases muscle mass, oxidative enzyme capacity, mitochondrial density, and insulin receptor expression, all enhancing insulin sensitivity. I implemented a 3-day per week resistance training program focusing on compound movements: squats, deadlifts, presses, rows. I trained in the 8-12 repetition range to mechanical failure, the stimulus for hypertrophy and metabolic adaptation. Studies show this protocol reduces fasting insulin by 20 to 30% within 12 weeks independent of weight loss. The second intervention was time-restricted feeding. I condensed all caloric intake into an 8-hour window, 12 p.m. to 8 p.m., fasting for 16 hours daily. During the fasting period, insulin drops to baseline, allowing continuous lipolysis and fatty acid oxidation. This metabolic switch from glucose to fat metabolism improves insulin sensitivity. Research in cell metabolism demonstrated that time-restricted feeding, 16.8 protocol, reduces fasting insulin by 26% and improves insulin sensitivity measured by HOMA-IR even without caloric restriction or weight loss. The mechanism involves enhanced autophagy, mitochondrial biogenesis, and circadian clock gene expression. I also incorporated apple cider vinegar before carbohydrate-containing meals. Acetic acid inhibits disaccharitases in the small intestine, slowing carbohydrate digestion and blunting postprandial glucose and insulin spikes. 1 tablespoon of vinegar before meals reduces postprandial insulin by approximately 20%. After 6 months on this insulin normalization protocol, my fasting insulin dropped from 16 to 7 MIU/mL, a 56% reduction. My HOMA-IR improved from 3.7 to 1.6, optimal 1.5. Most importantly, my blood pressure continued declining despite reducing medication. My kidneys were unlocked, sodium excretion normalized, fluid retention resolved. My complete daily protocol. This is exactly what I implemented every day for 14 months. Morning, 6:30 a.m., 70 ml concentrated beetroot juice, Beat It Sport, 5,000 IU vitamin D3, 600 milliliter magnesium glycinate, 300 milliliter dose. Black coffee, no mouthwash, only brushing and flossing. Fasted state, 6:30 a.m., 12 soir p.m. Water, black coffee, green tea only. Light walking, 20-30 minutes. Lunch, 12 sir p.m., first meal. Large arugula salad, 200 green raw arugula, cherry tomatoes, cucumber, radishes, 150 grain wild-caught salmon or sardines, dressed with 2 tablespoons extra virgin olive oil, lemon juice, sea salt, 1 cup mixed berries, green tea. Afternoon, 3 p.m., 20 green, 85% dark chocolate, handful of almonds, 30 green. Dinner, 6 p.m., 200 green grass-fed beef, pasture-raised chicken or wild fish, large serving roasted cruciferous vegetables, broccoli, Brussels sprouts, cauliflower, cooked in grass-fed butter, small serving properly prepared legumes, 1 tablespoon apple cider vinegar and water before meal, green tea. Evening, 7:30 p.m., 1,000 mg fucoidan supplement, 360 mg vitamin K2, MK7, 300 mg magnesium glycinate, second dose, 3 times weekly, 50 gram natto mixed with soy sauce, mustard, kimchi at dinner. Fasting window, 8 p.m. to 12 p.m. next day, 16 hours. Exercise protocol, isometric hand grip training, 3 days per week, 4 sets of 2-minute holds at 30% MVC with 1-minute rest. Resistance training, 3 days per week, full body compound movements, 8 to 12 reps to failure. Daily walking, 30-45 minutes nasal breathing only, eliminated completely. Refined carbohydrates, sugar, seed oils, processed foods, mouthwash, mouth breathing during sleep, used mouth tape. My measured results over 14 months. Blood pressure progression, all measurements taken morning, seated after 5 minutes rest. Baseline on lisinopril 10 mg, amlodipine 5 mg, hydrochlorothiazide 12.5 mg, 3284 mmHg month. 3, same medications. 12478 mmHg month. 4, eliminated HCTZ. 12680 mmHg month. 6, reduced lisinopril to 5 mg. 12276 mmHg month. 8, reduced amlodipine to 2.5. 12074 mmHg month. 10, eliminated amlodipine. 12276 mmHg month. 12, reduced lisinopril to 2.5, 11872 mmHg month. 14, eliminated all medications. 11874 mmHg recurrent, month 38, no medications. 11672 mmHg vascular function markers. Flow-mediated dilation, 4.2%, 9.8%, 133% improvement. Pulse wave velocity, 11.2 ms, 8.9 ms, 21% reduction in arterial stiffness. Your pulse pressure, 56 mmHg, 44 mmHg. Arterial compliance improved. Carotid intima media thickness, 0.94 mmHg, 0.78 mmHg, 17% reduction. Metabolic markers, fasting insulin, 16 mmol, 7 mmol, 56% reduction. HOMA IR, 3.7, 1.6. Insulin sensitivity improved. Fasting glucose, 94, 86 mg/dl. HbA1c, 5.4%, 5.1%. Triglycerides, 156, 78 mg/dl, 50% reduction. Oxidative stress and inflammation, a high sensitivity, CRP, 2.8, 0.7 mg/L, 75% reduction. Oxidized LDL, 6738 UL, 43% reduction. Body composition, not a primary goal, but occurred. Body weight, 182, 174 lbs. Waist circumference, 37, 33 inches. Body fat percentage, 22%, 16% by DEXA. Subjective improvements, exercise capacity increased substantially. Resting heart rate dropped from 76 to 56 BPM. Recovery between training sessions improved. Sleep quality enhanced based on wearable data showing increased deep sleep percentage. Mental clarity and sustained energy throughout fasting periods. No more afternoon fatigue. The most significant outcome. I've been completely off all blood pressure medications for 24 months. My blood pressure remains normal. My vascular function continues improving. I reverse the disease, not just the symptoms. Questions. I frequently encounter, can this protocol work if I've had hypertension for decades? Vascular remodeling capacity persists throughout life. The glycocalyx can regenerate, arterial calcification can regress, eNOS function can restore, insulin sensitivity can improve, regardless of disease duration. The process may take longer with advanced disease, but the mechanisms are universal. I had hypertension for only 2 years before implementing this protocol. Patients with 20-year histories have achieved medication reduction or elimination, though timelines extend to 36 months rather than 14 months. Do I need all 4 mechanisms, or can I just address 1 or 2? Hypertension is multifactorial. Addressing a single mechanism produces partial improvement. Addressing all 4 produces synergistic effects. For example, glycocalyx restoration improves no production. No enhancement reduces oxidative stress, protecting BH4. Insulin normalization reduces inflammatory signaling that damages glycocalyx. The mechanisms interconnect. Complete reversal requires comprehensive intervention. What if I can't do resistance training due to injuries or limitations? Isometric hand grip training provides significant blood pressure reduction without lower body or spinal loading. Even this alone produces measurable improvement. However, insulin sensitivity improvement from resistance training is substantial. If standard resistance training isn't possible, alternatives include resistance bands, chair exercises, or aquatic resistance work. Any activity that loads muscles to fatigue stimulates insulin sensitivity adaptations. Is this protocol safe for people with kidney disease or diabetes? The dietary nitrate, K2, magnesium, and polyphenol components are safe in chronic kidney disease and actually protective against progression. However, if you're on potassium-sparing diuretics or have hyperkalemia, magnesium supplementation requires monitoring. For diabetics, the insulin normalization protocol will improve glycemic control, but medication adjustment becomes necessary to prevent hypoglycemia. Close medical supervision is essential.